I hope that you have at least a couple of minutes to relax, take a deep breath, okay? And stretch a little bit, move your back so you don't get too much back pain. We are here actually to have a panel and discussion about acute flaximyelitis. Acute flaximyelitis is emerging as a very important concern for public health in the United States. Acute flaximyelitis appears to be an infectious disorder that is triggering an spinal cord damage. And unfortunately, this is reminiscent of poliomyelitis in the 20th century. I think that this is a disorder that is emerging in the past 6 or 8 months, but it's very likely that this disorder has been around and we never realized about that. And it's very likely that many patients that were diagnosed with myelitis and many children that were diagnosed with myelitis several years ago actually had acute flaximyelitis. And we never realized about that. So the importance of the panel this morning is we have a very good group of people that have been dedicated to acute flaximyelitis. And I'd like to introduce the group. And at the end, what I like to get is your questions, your opinions, your comment. Please feel free to speak out. What we like to get from you is your concerns, your questions, recommendations, suggestions for us. So the panel is comprised by a group of people that are dedicated to myelitis research, epidemiology, and it's extremely important to get this interaction with all of you. Let me introduce Dr. Ben Greenberg. You already know Dr. Ben Greenberg. I don't like to spend too much time on Dr. Ben Greenberg, but what I like to say is Dr. Greenberg has been a pioneer on studies on pediatric myelitis. He left Hopkins, but went to UT Southwestern to establish actually a very well-focused, dedicated center to examine and manage patients with pediatric and adult myelitis. And part of that, actually, he made the first major investment in studying outcomes in myelitis, in pediatric myelitis, and that was part of the CAPTURE study that was funded by PCORI, and that has been probably the first and only one dedicated to evaluate outcomes in transient myelitis. But I'm going to introduce Dr. Sarah Hopkins. I'm going to make a joke. Hopkins is not related with John Hopkins. Sarah is at CHOP, that is a very important institution in the United States dedicated to pediatric neurology and pediatrics. Is the Children's Hospital of Philadelphia. Sarah is a pediatric neurologist. She has focused on neuroimmunology, and she is the leader of a very large group of physicians and researchers at CHOP that is dedicated to pediatric neuroimmunology, and she is taking care of many of our patients with acute flaximyelitis, as well as patients with other neuroimmunological disorders. And she has also been one of the people that has been helping us to organize the group that we call Acute Flaximyelitis Working Group that is dedicated to bring together all of the physicians, healthcare providers, therapy, rehabilitation doctors that work around AFM. Next to Sarah is Dr. Janelle Roth. Janelle is a pediatrician by training, but she's at the CDC. CDC, as you know, is a federal institution that is dedicated to surveillance of different disorders that affect our population. And the role of the CDC is extremely important for understanding the public health of the United States and the world, because actually they do a lot of work not only in the United States, but around the world. And some people say, why they are doing work in other areas that are not in the United States? Actually, that's very important for us, because if we start bringing a lot of infectious disorders to our country, that's going to produce a major impact in the public health. So Janelle is going to help us in the next few minutes to understand what the CDC is doing for understanding acute flaccid myelitis. Next to Janelle is Dr. Christina Sadowski. You already know Dr. Sadowski. I'd like to make a further introduction because Christina is in Baltimore, that great city of the United States, and Christina has been a pioneer in neurological rehabilitation, and Christina and her group with Janet Dean and the rest of the people at the Kennedy Krieger have been very, very critical for developing new strategies to recover function in patients with myelitis. And Christina has invested a lot of effort as well in rehabilitation of children with acute flaccid myelitis, and she's going to give us an update about that. And next to Christina is Dr. Emily Everlin. Emily is a physician and infectious disease specialist. She's at the National Institute of Health, at the National Institute of Infectious Disorders and Allergies. And she is a scientist that is going to help us to understand what a federal institution like the National Institute of Health is doing for understanding acute flaccid myelitis. And actually, there are two representatives from the federal government here, the CDC and NIH, that are going to explain to us what our government is doing to tackle the problem of acute flaccid myelitis. And that is very important for us because we have the social responsibility to have a good response to a major public health problem like acute flaccid myelitis. Without going too much in the blah, 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 I like to go and ask one person that I know here that has been affected by acute flaccid myelitis. Jennifer, you are a mom. You encountered acute flaccid myelitis when your child, Jack, got hit by acute flaccid myelitis. Do you mind to explain to us in a few minutes what is the meaning of acute flaccid myelitis for a parent, for a child, and for everything around you?
How long do I have? I'll try to summarize. Jack was 3, perfectly healthy, fully immunized, didn't feel good, had a meltdown at preschool, came home, wouldn't eat or drink, tried to force fluids. Anyways, the next day he had not gone to the restroom. He hadn't peed. We took him to an ER. We spent about 8 hours there, and they said it might be an appendix. You have to go to the Children's Hospital. We can't help you. We went to the ER. They were about to do a spinal, get the fluid, what is that?
Spinal tap.
Yep. And the ER doctor ran in and said, stop, he's positive for strep throat. Well, my son can't move his arms or his neck. That's what he told me. At least he admitted us, and within 8 hours we were in the PICU, and within another day he was on a ventilator, intubated, and fully paralyzed. So we stayed 8 weeks in the PICU. We encountered multiple other problems while we were there, including ECMO and a hole in his lung. So eventually we went to Kennedy Krieger and saw Dr. Sadowski and Janet Dean and all the wonderful therapists, which was amazing. Well, let me go back. He had all of the treatments he had in the PICU. Steroids, IVIG, plasmapheresis. We even talked about trying rituximab, but nothing seemed to help. He could wiggle his toes when we left. Now, after being able to go to Kennedy Krieger 3 times, and continuing with therapy at home, which is a lot of work, and Jack's now in first grade. He can move his legs. He can't walk. He can't stand. He can sit for a few minutes. He can hold his head for a minute or two. He has wiggles in his fingers. So it has just an incredible impact on your family. You're in shock. It's a nightmare. This is your little boy, and you have hopes and dreams for him. You have to readjust that. The stress on your relationship with your significant other, it's just unbelievable. Then trying to navigate through, who knew that my son is on a ventilator 24/7 and Blue Cross Blue Shield won't help. They don't pay for any home nursing. So I have to get Medicaid for him to help pay for that. It's just all these things you have to learn to navigate within a short amount of time is incredibly difficult. And the services, the equipment, the medicine, the 10 doctors that we see for different problems that have arisen because of this. And we have our extended family that's helping as much as they can monetarily, putting a strain on them. Just I'm therapy. I'm in. We're there. So it's just an unbelievable, horrible thing that can happen.
Jennifer, thank you so much for sharing this story with us. I think that what you have pointed out is the multiple dimensions of acute flaccid myelitis. It's not only the medical problem, it's not only the family problem, it's also the social problem, and all of the dimension of this disease that is going to produce a long-term impact. It's not a matter of days, it's not a matter of the hospitalization during the acute phase, but it's the long-term situation. And thank you, Jennifer, and we will wish you and your family the best. But I'm going to ask Dr. Greenberg, after listening Jennifer, so why is Jennifer here? Why is acute flaccid myelitis in this meeting related with rare neuroimmunological disorder? What is your opinion about it?
What Jennifer and Jack went through, what your family went through, is interrelated not just socially, culturally, and just the human experience with what a large number, if not everybody in here, went through. There's the social and the scientific answer. For anyone who's read Sandy's book, that was how many year labor? It was, I've heard about this book for a long time, but it came out. Doug Herr and I wrote a foreword for it, and we were started off by saying nobody asked to be part of this club. Nobody really wants to be here, not just because it's Columbus, Ohio, no offense to Columbus, Ohio, but nobody wants to be in a room for this reason. These are all unwelcome guests into our homes and into our families. And whether you carry the title AFM, the letters ADEM, the letters NMO, the letters TM, the letters don't matter. They are all unwelcome guests in what we do. And so, irregardless of the type or cause of damage to a spinal cord or to a brain, there are commonalities that exist amongst all of you, and a lot, and we talked about this yesterday, that we can learn from each other regardless of the mechanism of injury. And so just at a social level, there's a reason for us all to be under this tent, and in fact, in some respects, that's more important than the science, just from a community perspective and coming together. But scientifically, this question of so many different disorders being grouped together, and especially one like acute flaccid myelitis, which has such a focus on infectious disease, and I'm so thrilled that Janelle and Emily are here, and from a community perspective, I'm very thankful to see leadership from CDC and NIH take time out of your days and your work to travel here and take part of the community. It's very appreciative. We're very appreciative of it. Why would something with such an infectious disease fit in neuroimmunology? And there are several scientific reasons. So number one, you'll notice that the name of the organization is the Siegel Rare Neuroimmune Association. It's not the Siegel Rare Neuroautoimmune Association. And there's a reason for that. So when the immune system gets activated and causes damage to the nervous system, we think about it getting activated in two ways. It can be activated inappropriately and enter the nervous system for the absolute wrong reasons, causing damage, or it can be activated appropriately. There is a reason to go into the nervous system, but despite there being an appropriate reason, it can still cause damage. And we see this pattern of interaction between infections and immune-mediated damage to the nervous system in lots of different conditions. And AFM is likely no different. And so when we have children and some adults, but obviously more often in children, becoming paralyzed by this syndrome, if it is, and we firmly believe that there is an infectious trigger of it, the infection isn't the sole cause of damage. And there is a role for observing, testing, and trying to classify children with AFM to the extent of immune-mediated damage happening in the nervous system, because immune-mediated damage can be treated in a similar way that we treat the immune system when it's there inappropriately. So there are scientific and clinical reasons to be in this same tent, because a lot of what we're learning on how to manage the immune system in AFM comes from what we learned from transverse myelitis when it was an inappropriate activation of the immune system. And the last point I'll make in terms of why to be under a bigger tent like this is, and I apologize, I'm forgetting if it was Cindy yesterday who was giving the MOG presentation. But if everyone will remember, there were the presentations during the MOG antibody-associated disease where the spinal cord illness meets all the criteria for acute flaccid myelitis. And if I were to send a case of, just to give Janelle heartburn, of MOG-associated spinal cord disease and hide the fact that I had a MOG antibody positive, it would get scored as acute flaccid myelitis, clinically, radiographically, in every way, shape, or form, and then I'd say, surprise, this is an immune-mediated disorder. And so syndromically, acute flaccid myelitis has lots of potential causes. Between July and November every other year, we feel as though there's an infectious cause of the majority, not all, but the overwhelming majority of the cases, and that's where the studies are going to go, and we'll talk about that in a moment. But there are a lot of reasons for us to do this together, because for all of us, whether a virus was involved or not, at some point the immune system plays a role in the damage that yourself or your loved ones suffer.
Thank you, Ben. So, Sarah, you are in the front lines in the major hospital in Philadelphia dealing with acute neurological disorders. So what has been the impact of acute flaccid myelitis and the emergence of acute flaccid myelitis in your practice, in your activities? And what is the main take-home message for all of us about your experience with acute flaccid myelitis?
Well, I think that some of these things are things that I talked about yesterday. And I think that the main issues for us have really related to education of the community and education of providers to help make sure that we're recognizing things early so that people don't get told that they have strep throat. And, you know, luckily you guys were admitted, but, you know, sometimes those children are being sent home. So it's really been, and that clearly would have been a bad thing if you guys had been sent home. So really working to educate everybody from the health department to outpatient providers to local emergency room doctors and a full court press in terms of that, and also working with our emergency department and our fellows so that we can get workup done quickly in the emergency room, identify those kids early on, and also so we're sure people are documenting all the appropriate exam findings, and they're thinking about looking for subtle signs of weakness. And keeping that full differential in mind. So I think those have really been the main issues as a system. And you know, I think the most difficult times for any of our institutions are probably during these times with increased cases, because when you have, you know, in 2016 we had 9 patients that came in really close proximity. So organizing and taking care of that many patients with this diagnosis at once can be taxing, you know, for the team as well as all the families. And so making sure that that everyone is up to speed on the latest information about AFM, on how we should be taking care of this, on anticipating a discharge, what rehab services they're going to need. You know, a lot of our patients are from several hours away. They're going back to places where the physical therapist has never heard of AFM, and you know, they want to do you know, what's called episode-based physical therapy. So if you're not making great progress, sometimes they'll say, okay, well, let's take a 2-month break and see what happens. So if you do that with AFM, especially early on, those patients are going to regress. Their scoliosis is going to be worse. There are a lot of issues with that too. So so making sure that everything is in place in a systematic manner. And I think as we gain more experience with this, really just, you know, making sure that everyone's on board, kind of doing things in a systematic manner, making sure tests are sent appropriately and follow-up is appropriate, without going so far as to make everything so algorithmic that people aren't thinking through the differential, aren't thinking through, you know, whether there's, you know, gray matter involvement, white matter involvement, what the best management is for that patient. I think is really important. Just have a protocol so things aren't getting missed in the process.
Thank you, Sarah. Janelle, so first, thank you so much for coming to Columbus, and I say thank you because all of you. Because we, and I include myself, we always say, well, what is CDC, what is NIH doing for this problem? And actually, it's great to have you and Emily here, because we are a big family. It's not only family on this side, it's the family of everybody who is involved in TM and neuroimmunological disorders. So we have a major challenge, AFM. Give us an update about what is the role of the CDC and what are you doing for understanding AFM, but particularly help us to understand what is CDC major goal in AFM.
Thanks, Carlos. I'm trying to juggle those questions in my head. I think overall, certainly for the study of rare illnesses, CDC can be particularly helpful. We sit at the national level. And before I get too far into my answer, I do want to say that just because we do sit at a national level doesn't mean we don't partner with many people across the country. So the work that I'll talk about in a minute is the joint effort with both state and local health department partners. It's with our academic partners, some of whom are on the panel today. And then I think one thing I'm particularly proud of are our parent partners. So something that really developed as a result of the 2018 AFM outbreak or increase in cases has been more of a partnership between CDC and the parent organizations. And I hope that will strengthen in the years to come. What does CDC hope to do for AFM? I think we would like to provide some answers. And maybe that will be more clear in when I talk about what CDC is currently doing. I think about our activities in 3 major buckets. One is surveillance, so looking at the epidemiology and risk factors for AFM. The second is in the work that our laboratory is doing to promote diagnostic testing and to determine etiologies for AFM, so what is causing this illness. And then finally, this gets back to something that Sarah mentioned, is communication. And I think I can say from listening to everybody's stories over the past couple days, that is the area we can really work to improve in the next 9 months before a possible increase again in 2020. So I'll speak a little bit high level about our activities, but certainly if any of you have questions about the more specific questions about the activities we're doing, I'm happy to answer questions, and you can always reach out to us through various email addresses. We have an AFM info inbox. You can go to our website and look for these addresses, and you're most welcome to send us questions. We are a fairly small team on our surveillance side, but we really love hearing from the public and having a dialogue. So to speak a few things about our surveillance activities, one thing that we are really interested in learning about are accurate case counts for AFM. So we know that right now we rely on clinicians to report to their health department, and then the health department to report suspected cases to CDC. That works particularly in states where there's high awareness of AFM, but it often doesn't work in other states. So one thing we're trying to do is implement more active surveillance for AFM. So really going into institutions, academic institutions, and partnering with their infectious disease and neurology departments and say, hey, every week can you go and look on your pediatric rosters for cases of acute flaccid weakness and start that reporting process. So really not just waiting for cases to be reported, but actively looking for them. So we've started those partnerships at 7 hospitals across the country, and we're actively engaged with 10 other states to increase that active surveillance for AFM. The second thing we're doing is to look for risk factors. So I think Mike Levy gave that great talk on genetic risk factors for transverse myelitis. There's work being done at Johns Hopkins. Priya Dugal is doing some great work with genetic risk factors for AFM. From the CDC side, we're looking for more environmental risk factors, so conducting interviews with patients and their families who have had AFM to look for some of those risk factors, and then see if we can find commonalities between the cases throughout the country. From the lab side, I think one big goal for us is really to determine the etiologies for AFM. There's been a lot of discussion. I think we're all of the mindset that enteroviruses are a likely trigger for AFM. Do those increase in cases every other year? Are they the result of one enterovirus or multiple? So continued diagnostic testing is very important for our laboratory. I think you're also aware that it's often difficult to isolate different viruses from the samples we receive from AFM patients, so our laboratory is busy looking for other means of testing, so developing other diagnostic tests, maybe not direct tests for the virus, but indirect tests for antibodies against a virus that might help explain infection in patients with AFM. And then finally, the communication side is really spinning up. We've just partnered with an organization to do some research with providers, both emergency and urgent care providers, as well as neurologists and infectious disease doctors, to just quantify their awareness of AFM, and this will take place nationally across the country. We're hoping that the results from those conversations will help us develop better education and outreach materials moving forward into 2020. So I'll stop there. I could talk for an hour, but if you have specific questions, please do reach out or ask today.
So, Janet, let me ask a question. So if Sarah sees a patient at CHOP and she diagnosed with acute flaccid myelitis, does she need to wait from the CDC to confirm the diagnosis or not?
Carlos, that's a great question. So one thing we really would like to emphasize is the difference between diagnosis and CDC case classification. The CDC case classification should never, ever supersede or change the diagnosis of a patient. The two are very separate processes. So we emphasize that diagnosis should happen at the bedside in conjunction with your care team, neurologists, infectious disease experts, everybody that's at the bedside actually seeing your family member, the patient, and doing those diagnostic tests that determine that diagnosis. And then moving forward, you should be treated based on that diagnosis, both acutely and then in the long term. Our surveillance efforts are for a different purpose. So we conduct surveillance for diseases in order to understand the burden of disease, so how many people are affected, and then trends over time. So what does this illness look like from one year to the next? In order to do that, we need to make a bucket of patients who we know specifically have that disease. So, for example, AFM. So we design a case classification, a case definition, and we count only those people that fit into that very specific case definition. That doesn't mean that other people don't have this illness. It just means that we're using that specific definition to follow trends from year to year. And I really do want to emphasize today, as well as in all of our materials, that whatever classification CDC might give to your child should never supersede or take away from the diagnosis that you've been given by your doctor.
Thank you, Janelle. It's very helpful to understand that process. So, Emily, I'm going to ask you a question because Janelle mentioned risk factors, mentioned viruses, and mentioned surveillance, but so that involves a lot of research. So, and we appreciate very much that you, as a representative of NIH, is here today. But we'd like to understand, number one, in the same way that we got the explanation about what is the role of the CDC, what is the role of NIH, and what are the plans that NIH has for tackling the problem of acute flaccid myelitis?
Yeah, so I think the first thing that we're at NIAID, the National Institute of Allergy and Infectious Diseases, we're interested in doing is identifying the pathogen. We're fairly the pathogenic process. You may know, as Janelle mentioned, that some of the cases over the past several years in the United States, enteroviruses, those are cousins of the polio virus. That virus family has been strongly implicated in the community outbreaks, and in a handful of cases have been isolated from patients that clearly had acute flaccid myelitis. So if we have a pathogen and we actually have the viruses that we can grow in laboratories, we can do things that might down the road provide benefit to, development of, assist us in developing a therapeutic, for example, or a vaccine, for example, or really importantly, a diagnostic. A diagnostic might be based upon direct viral detection in a laboratory or indirect, immune response that is consistent in cases that was against that particular virus. So we're trying to fund, we're funding a natural history study. Carlos, this group of people at this table, many of you have been involved in the process over the past several months, where samples will be collected from AFM patients or patients that present who look like they have acute flaccid myelitis. Consistent sample collection, meaning cerebral spinal fluid, blood cells, will be systematically collected sort of at the same time interval on patients, along with their clinical features, their neurologic exam features, and their radiographic imaging. In addition to that, because it's, one of the big puzzles here is within a household, why do some kids just get a runny nose, and why does the brother or sister get paralyzed and end up in an ICU? Nobody can explain that. This natural history study, part of the protocol would be to ask, in many cases these are going to be parents that give consent, to bring in the household members, related often, brothers and sisters, to also give samples that are contemporaneous, roughly, with the samples collected from the AFM cases. And that may allow scientists to probe more deeply some of these questions related to genetics or other vulnerabilities that might have made a case, and somebody else in the house that might have had a runny nose, a non-case. There are hypotheses out there as to why that might happen, but we don't understand that at all. Those are some of the areas of research that are actively being supported and will continue to be supported over the next several years. Of course, there are other things that need to be done that aren't so pathogen-focused. Regenerating central nervous system neurons, you heard more about that. That's not the institute that I work for. That would probably be National Institute of Neurologic Disease that would fund those types of studies, but they are interested in this. And then in addition to that, just the best rehab techniques for rehabbing over the long run. Also, research in that area is needed.
So Emily, this is a community of families affected by neurological disorders and patients affected by neurological disorders, including AFM. How families, patients may help in research? That sometimes we see NIH on one side, we see the community on their side. So what are the options and strategies that families may have in the future for getting connected with NIH and the resources available at NIH?
So on campus, there's a clinical center, and there are neurologic protocols. We're talking now specifically about AFM, but there are protocols that you may be eligible for. There's a website that you can peruse, and so people from all over the country do get tickets to the NIH funded by the federal government, and they come and participate in protocols in the clinical center, which is a hospital, and their families stay at, sometimes on campus. There's an inn there. Now that's if you're eligible for protocols on campus. Now, our institutes also fund academic institutions or research institutes, private research institutes throughout the world. And the connection there is through the extramural investigator, like Carlos or like Ben or like Sarah Hopkins. So there the connection to the NIH is not so direct, but yet the research is funded through the federal government through the NIH grants and contracts.
Thank you. So I'm going to ask Christina. Christina has been in the front lines of AFM since the beginning, even before she knew that there was AFM, right? So Christina, what is the impact that AFM has produced in your practice and at the Kennedy Krieger, and what is AFM different to other conditions that you deal with, like NMO or multiple sclerosis or other conditions?
So the impact of any child afflicted by paralysis is tremendous. I cannot quantify it in any way. There are differences in between children with AFM and children with transverse myelitis or NMO, in the sense that they present maybe with spasticity versus flaccidity. As they grow, there are common complications that are musculoskeletal and metabolic, but they diverge somewhat, more scoliosis, more hip subluxations. The fact that the children with AFM are afflicted that, well, originally it was 2 or 3 years old that were afflicted. Now it's more of a 5 and 6, but earlier than maybe of the other children. But in the long term, paralysis does the same to every child. It stops, it interferes with how they develop in a social, physical, educational, psychological way. So I can't say that this paralysis is different than any other paralysis. In my practice, every child with paralysis requires lifelong of intervention. Right now, we don't have a cure, and exercise therapy is the only thing that we know that it improves the quality of life and day-to-day living. It requires a lot of work, and Jennifer talked about the impact of paralysis in her household. Well, multiply that by 538, which is the numbers that we have right now, but as we said, we were talking about before we had the definition in 2015, there were still children that had flaccid paralysis. We just gave them a different name. You know, I remember calling it transverse myelitis with polyradicular involvement. And then going back, you know, we figured out, we actually just published a case series of 31, 17 of the children were before the definition. And lifelong consequences. They are still our patients or patients that require care. As Ben said, it's not important to go to therapy, it's important to do therapy. And you know, we put a medical term to therapy, but it's actually day-to-day living. We move around. I'm moving my hands, shaking my legs when I talk, moving. Well, that is non-existent in children or adults with paralysis, but that's what is needed in order for the nervous system to have a healthy development and maintenance, and that is taken away. So in the long term, this is therapy is not really therapy, a medical intervention, it's a lifestyle.
Thank you, Christina. Alex, I'm going to put you on the spot. And thank you so much for sharing with us your story. Do you mind telling us about what was the impact that AFM introduced in your family, your child, but most important after that is please let us know what are the major concerns and major recommendations that you may have for us. I don't know if, or in other words, let us know what you like from us so we can invest in work and effort to solve some of those problems. Do you mind, Alex?
Sure. Well, earlier I got to speak with Janelle, and we kind of spoke about some things. And I know like a big issue in our parent group is that a lot of us aren't confirmed, and it may be due to, you know, the records that were sent at the time, even though we know later on that that is the case. So she talked about maybe leaving it open for a longer period of time until they had a definite diagnosis. That was one of the suggestions that I had. And then just the communication with the parents, if that could be a little bit more fluid so that, you know, we know if our case was reported, and, you know, just to follow up with us and to follow our children, because up until this past year, nobody was being followed. So how can you find, you know, therapies and treatments that are given in the hospital if you don't follow the children? So I'm thankful that they're taking part in that now. As far as my son, it's affected everything. He hasn't been to school in 2 years. He's currently in his right grade because he has a home hospital teacher, but he's missing out on the social interaction. He's having a lot of depression, a lot of anxiety. He doesn't get to do things that normal kids get to do because, like you said, it's a lifestyle. We're constantly at the doctor, or we're at therapy, or, you know, we're trying to work everything into our schedule. It's a financial burden. I pretty much had to all but quit my job, so we're down to one income. Insurance is a huge issue for us. Just like she said, you know, we went home with a child on an event. We had to apply for Medicaid because, you know, our insurance denied any type of, you know, care after we left. You know, it's just, it's affected us in every way. I mean, Shane used to be athletic, basketball player. he's over 6 foot tall. He's 6'4" now, and now it's like, he doesn't get to do the things that he loves, and so it's just been, it's crushing. Every day is crushing. Every day I wake up and it's a nightmare. It's not what I expected my life to be, and we keep fighting. We keep trying to find things that help. We've done nerve transfers, muscle transfers. We go to therapy, and that's all we can do. And we just hope that we can figure out why, so that other kids don't suffer, because every year that it happens, I see it, and it just kills me. It kills me.
Thank you, Alex. And I think that your story and Jennifer are a reminder to everybody that we need to keep fighting for getting better things. And it's really, really difficult to hear that insurance companies don't cover support for these patients. But that is a matter of another conversation that need to continue, and we need to emphasize on that conversation. But I'm going to take two elements of your description. The first is for Janet briefly. Do you mind clarifying about the communication fluidity? And later, Christina, do you mind to basically make a comment about depression and anxiety in these children?
Carlos, thank you. And Alex, thank you so much for your comments. So we sit at the federal level, CDC, and most of the communication that we are able to do with patients goes through the health departments. So we, I think there's just a rule that this, because our families and patients reside in a certain state, all communication, particularly around illness, classification, diagnosis, laboratory testing, must go back through the state health department in order to be communicated either back to the family or to the clinician. So it inserts a bit of a middleman. We've certainly been working to strengthen those lines of communication between CDC, our health departments, and then making sure that the information gets communicated from the health departments back to either parents or clinicians. But I do recognize that has not always gone perfectly. So it's certainly something that moving forward, and in particular for 2020, I think we would all like to say we hope that there are no cases in 2020, but if history is to be believed, we will likely see another increase. And so having plans of action in place before that time is incredibly important. And one of those plans of action is better communication between CDC and what we are doing in our offices and getting that information back to parents. So certainly something that we understand and are working on to improve. Do I want to say anything else? So I think I just did want to mention our conversation a little bit earlier about case confirmation. And again, I mentioned earlier that we do want to distinguish case confirmation from diagnosis, but I think I heard you at the same time say having my case counted is important because it adds to the numbers that CDC reports, and those numbers then add to advocacy, the ability to advocate for increased funding at the federal level. I think, again, I really learned a lot over the past couple of days about the fluidity between diagnosis and thinking about some changes that we could make to our case classification process to just do that a little bit better. So.
Thank you, Janelle. And I'm going to make an editorial comment. The Acute Flaccid Myelitis Group that is working very close with the Transient Myelitis Association has designed an alert system in which parents are able to communicate through the TMA, and Gigi put together a very nice website. And Gigi, do you mind to explain in 30 seconds what you do with the transient myelitis?
So you mean the consult request?
Yep.
Yeah. So if any physicians have a potential case of AFM that they would like to chat with Dr. Pardo or Dr. Greenberg about. They can fill out a form where we get their name and information and a just brief summary, and we reach out and connect them so that they're able to consult and get care as quickly as possible if it is indeed an AFM case.
Thank you, Gigi.
Yep.
Carlos, can I add something quickly?
Yeah.
I would just say this is an incredible opportunity. And so oftentimes, I think physicians, for lack of other resources, call CDC, they call our Emergency Operations Center in order to get connected with somebody who might be able to help with AFM. CDC personally does not offer clinical advice. We don't sit at the bedside, and so it's very difficult for us to offer advice on a patient that we're not seeing. So this is a really amazing opportunity, and we thank you all so much. I've over at least, I think, 15 times since this was instituted have offered this service to physicians calling CDC. So it has really improved our ability to offer help to clinicians that call.
So Alex, part of the communication problem is also on the side of the physicians, because we need to basically facilitate that communication with families as well as with the CDC, and in the future even with the National History Study that NIH is leading. So I hope that in the next several months we don't get too many of the trouble with AFM, but I think that we are a little bit better prepared. We are. Christina, do you mind helping us to understand one major concern that we have is depression, anxiety, and the long-term consequence in mental health for these children with AFM?
So we don't have long-term data yet. As a care provider to children that are past the ICU and acute stage and into the subacute and chronic care, what we noted is that there is increased incidence of anxiety and depression, but anxiety for sure, to the point in which anxiety is detrimental in their ability to wean off a ventilator, even if they have the pulmonary capacity to get off the ventilator. The anxiety is preventing that vital conversion from vent-dependent to vent-independent. So we definitely need to do a long-term good job into managing the psychological consequences. But as of now, that's basically where I'm going to stay because we don't have long-term data.
Thank you, Christina. Jennifer, do you mind helping us? Are we missing important points in the discussion? How many minutes do we have for the panel? I think I lost track of the time.
We're a little over, but we can hit a couple
so
more.
Jennifer, help us to basically wrap up the panel. So what are the things that we have missed on the discussion?
What are you missing? I don't know. I mean, I'm 3 years into this, and who knows what other things I'm going to encounter. What Dr. Sadowski just mentioned with the anxiety is a tremendous problem. Jack is having that now with the ventilator. Just keeping, getting information to the public health at the state level, to the children's hospitals and the other hospitals is so important, you know. And also, I'm sitting here thinking, how can, you know, there's the year that Jack got acute flaccid myelitis, there was, I think, 230 or so in 2016. So we all live across the country, and we all have access to the hospitals and the doctors. And how can we help get information to them? We're there. I still talk to these doctors. What can we do?
So that's a very important question, and actually one of the major goals of the acute flaccid myelitis group that is working together with the Transient Myelitis Association is precisely facilitating education for healthcare providers. And we have discussed in the past 12 months ways to improve diagnosis, ways to expedite treatments, ways to produce better management with rehabilitation. So we are planning activities, educational activities. We are generating consensus among physicians because actually in 2018, we even didn't have a good consensus on how to make a diagnosis of AFM. So we are working on that, and I will, since we have only a couple of minutes, I'm going to make a pitch here is Ben emphasized that AFM is part of this association of neuroimmune neurological disorders. Every contribution that you are putting there for the association is going to help us to facilitate the phone calls that Gigi organized. I mean, we pay a provider for help us to organize a phone call every month, for example. I mean, every contribution that you are providing us help us to fund Ben Greenberg, Sarah, our fellows that are doing research on AFM. And so every penny that you are putting on the association actually is helping us in the mission to facilitate education. I will say we need to be prepared, and the only way to be prepared is educating our colleagues, healthcare providers, to identify, understand, and provide better management. I was reading the news this week that polio is coming back to some countries. I think in the Philippines, there is an outbreak of polio. Voila, after controlling polio in almost every part of the world, polio is coming back. Measles is coming back. So we need to be prepared in every front to make sure that our children are healthy and they have a better quality of life. It's our responsibility as adults just to make sure that they have a good life in the future. 30 seconds, last message in 30 seconds, Ben.
Just to directly address what you asked, Jennifer, there's actually a critical role all of the families can play that will change the course of all of this. And that is, as new families hear the words acute flaccid myelitis and you think back to those days in the PICU, and you think back to being alone and afraid, working with a healthcare team that hadn't heard of this before and were working on it on the fly, families reach out to other families before they reach out to us, very appropriately. And you are now, unfortunately, an ambassador for what should happen. And the biggest role I think families can play, one of the huge roles they can play, they play a lot of roles, but one of the huge is in those first 24 hours, pushing the families who are contacting you to do two things. One, ensure their clinicians are reporting to their local health department immediately that there is a case. Time matters for this. And secondly, as a carrot, so that their clinicians don't feel like they're doing all the work with no help, if they go online and just literally put in 2 sentences, within 24 hours, Carlos and I, 365 days a year, will get on the phone with them, clinician to clinician, hear about the case, and offer any advice we have. And then we're going to remind them, have you reported to the local health department yet? I don't care that it's Saturday. Go ahead and report to the, don't throw away the specimen that's in the lab. They're going to want that. We can give them advice on how to make sure that the resources go to the CDC, to our officials, so that they can start answering these questions. But you're going to be contacted before us, and so you're now an ambassador for this, and it will go a really long way to solving a lot of this.
Thank you, Ben. Sarah, any additional comment?
So I think just the one other loose end I wanted to wrap up, the question about families who haven't heard at this point whether or not their case was confirmed, if people are interested in that, and emphasizing what Janelle said about the difference between confirmation from CDC and true diagnosis. But I've had to do it several times when I see somebody as a second opinion and they haven't had that confirmation. All it takes is to contact the health department for the area where they live, and if the physician has a signed release from the family, they're able to reach out to the health department and get that information. It does have to come from the health department and not the CDC. So I would like to be able to just ask Janelle, but it doesn't really work that way. I have to formally request from the health department. But usually I have the answer within 24 hours. So.
Janelle, any last minute comment?
I was just going to highlight what Rebecca's been doing, which I think has some real benefit. So CDC in July put out what's called a vital signs report, and these vital signs highlight specific areas of public health interest, and so the July report was on AFM. In addition to publishing our surveillance data, there are lots of different tools to educate people about AFM, and one is a fact sheet. So just printing some of those fact sheets and spreading them across your care team might be a way to increase awareness and understanding about AFM amongst the medical community. So I'll put that as a plug to continue to educate. You can actually advocate and educate your healthcare provider team.
Thank you, Janelle. Christina, last minute comment?
I'm encouraging the families that have children with AFM to return to the healthcare providers that have knowledge on it, so we can record and document the changes that your children are going throughout life, because this is the only way that we're going to learn how this disease is going to affect long-term the population.
Thank you, Christina. Emily?
So I think I would just say, through your family groups and your support, your Facebook groups, encourage the participation of people diagnosed with AFM to participate in research if they're eligible, because that's probably the only way that we're going to get better answers and be able to improve care in this condition.
Well, I'd like to thank you, all of you, for being patient and staying all together. Jennifer, thank you. Alex, thank you. We wish you the best. And for all of you parents and patients, again, remember that our motto in the next several years is going to be stronger together, right? Repeat with me, stronger together. And stronger together, because that is the new motto of our association. Just keep moving forward. Thank you.